So the patient continues on treatment for several months. She has relatively stable disease. Her symptoms are controlled on 400 milligrams daily. And on a monthly visit, she later comes in about 10 months later, and she has evidence of some liver decompensation. At this time, she's developed some ascites. Her bilirubin has risen to 2. Her albumin has fallen a little bit. And the question becomes, how do we manage her? So this is someone who on imaging has had relatively stable disease, but now has progression in some decline in liver function, which is not uncommon, whether this is the natural history of her liver disease or even sometimes subtle changes in her tumor that we can't really pick up on a scan can cause stress on her liver and further decompensation. So we have a few choices at this point. One is to recognize that she has an incurable malignancy, and sorafenib has been shown to extend survival to help control tumor growth. But this patient, based on her clinical course, likely will succumb to her liver dysfunction at some point. And whether or not we continue sorafenib or stop it or change to another agent are our course of action. Depending on her sense of well-being, I think it's very reasonable to just continue sorafenib in this case. We know that sorafenib has never been shown to improve survival in patients who present with Child-Pugh B, but this patient's a little different in that she had been on sorafenib for some period of time and now is decompensated a little bit. But if her performance status is preserved, she can come to clinic, she's not having significant side effects otherwise, I think this is a patient we could continue on treatment in hopes that we're still getting a benefit by slowing down radiographic progression, even though she has some clinical progression. The other option would be to stop treatment altogether. I think that would be a very appropriate thing to do if she had a decline in her performance status, if she is not feeling well, has other stigmata of end-stage liver disease, such as continued weight loss, muscle wasting, with the idea that continuing sorafenib in that setting may not be of any benefit. At this point, we have no drug that's been approved in the second-line setting. We know data from the RESOURCE study, or this is the study that evaluated regorafenib in the second-line setting of advanced liver cancer, was a positive study. In that study, we took patients who had progressed on sorafenib radiographically, but were still Child-Pugh A in good performance status, and those patients were randomized to regorafenib or placebo, and that has been shown to improve survival. At this point, she doesn't really qualify for that type of treatment. One, it's not FDA approved as of yet, but also she would not qualify for that proven survival advantage because we don't know the role of that drug in a patient who's Child-Pugh B. So I think at the end of the day, our choices probably would be to continue sorafenib or not. This patient decides to continue on sorafenib in consultation with her physician, 400 milligrams daily, and she would be followed until she has evidence, I think, of further clinical progression. You know, as we start thinking about treatments for second-line liver cancer, it'll be important to try to find patients who qualify for proven second-line treatments, and that will be patients who have radiographic progression but also have preserved liver function. And we'll have to maintain an active treatment role in our patients to help get them, to optimal treatment regimens.